of Medical Sciences, Dr. Ramesh Jonalagada, Senior Lecturer in Surgery, other colleagues of the Queen Elizabeth Hospital and the University of the West Indies, other specially invited guests, ladies and gentlemen, good evening again. My name is Christiane Walcott, and I'm pleased to perform the duties of Master of Ceremonies for tonight's public lecture. Just by way of housekeeping, anyone interested in using the restrooms can be found just outside the auditorium to the right of the elevator. Tonight's feature presentation, entitled Managing Kidney Stones the Modern Way, will be delivered by visiting consultant urologist with RG Stone Urology and Laparoscopy Hospital in Chennai, India, Dr. Jeevagan Murugesan. Dr. Jeevagan joins us this week as part of UWE's Campus Lecture Series program and has been with us since June 14th. Some of you may have caught him on earlier this week when he was on Morning Barbados, where he discussed certain aspects of kidney stones and prostate cancer. And tonight provides a greater opportunity for him to share and for us to learn more about these areas. To formally launch tonight's program, I now invite Dean of the Faculty of Medical Sciences, Professor Brandy, to bring an official welcome. Dean?
Thank you very much, everyone. If you know my voice normally, you'll realize I'm not exactly speaking in the normal way. So, first of all, I apologize for the late start, and on behalf of the Faculty of Medical Sciences here at Cave Hill, and particularly the Academic Department of Surgery, we welcome our guest speaker and all of you to this public lecture. And there's something good about having a small group. There's lots of opportunities for questions and answers afterwards. So I welcome you all. As I said, I bring you greetings on behalf of our faculty.
Thank you, Prof. Brandy. Good evening, Christiane, my colleagues, and a few public from the audience. I invited Dr. Jeevagan. We call him Jeevagan. I'm Dr. Ramesh. That is my first name. I've been here 35 years, and people know me only by my first name. My real name is Jonalagada, but it has to be said in a very Indian tongue. We all have our own accents. I went to Guyana once, and in the remote forest, I heard a Bajan accent. You won't believe it. And he was settled there 40 years, apparently. So we all have our accents, and we keep our accents. We should be proud of our accents. Anyway, I hope Dr. Jeevagan will be clear in his delivery of his speech. Dr. Jeevagan, we invited Dr. Jeevagan mainly for two reasons. One, we need to upgrade our urology way of treating diseases, and he has some skills in laparoscopic surgery that like in kidney and adrenal disease, and so I thought his visit here will be useful not only for the public in terms of educating them on prostate and kidney stones, but also for the residents and the medical students. He's been teaching the medical students the last few days, and he has been teaching the residents, surgical residents in training in urology and urological diseases. And he also performed a state-of-the-art keyhole surgery to remove an adrenal gland, which is very remotely placed in the body, and that was done successfully. And I'm sure our surgical residents in training learned something from this procedure. So we normally don't take too long to introduce our surgical colleagues, and therefore I invite Dr. Jeevagan, who is a very accomplished endoscopic urological surgeon from Chennai. Just to note that Dr. Jeevagan was here 10 years ago and has a senior registrar at the Queen Elizabeth Hospital. And since he left, he gained tremendous experience in endourology. And I am encouraging our residents to go to him to learn, to spend a month or a few weeks to see the state-of-the-art procedures and come back and do it in Barbados, so that we don't need to make a big cut to remove kidney stones in Barbados. Welcome, Doctor. I introduce and then welcome Dr. Jeevagan to give his delivery of his talk.
Good evening, ladies and gentlemen. It's a privilege to come to Barbados, where most of my open surgical knowledge and confidence started from here. When I came to Barbados in 2003, I just completed my urological training. In India, unlike in Barbados, most of the surgical training starts after finishing the degree, unfortunately, because we have large number of residents who will not be able to perform all the surgeries. Unlike here, that time I saw where the SHOs, registrars perform more better than a post completed surgeon. My surgical career from a person who was very anxious to operate to become very strong, confident to operate started here. And once I gained a lot of knowledge in open surgical technique, I was looking at urology, where the world has moved from open surgery to endourology, laparoscopic urology, and laser urology, probably 2 decades back. And I realized I need to move on and identify which place is best to me. So I am going to give you recent changes in management of stone disease. Before you plan any treatment, you should know some basic idea about stone disease. And this is a problem which affects commonly up to 10 to 15% of the population, younger age group people, more in the male population. And even though it is mentioned it is more whites, I am coming from an Asian country where I work in a big stone center where nearly 80 to 90% of the work what we do is stone related procedures. And as it is hot climate and dry climate, people live in mountain are the common people who get stone disease. People who are sedentary tend to form stone disease. People who work in hot environment like cooks and people who are in the marine job, people who are flying, the people to be more cautious about stone disease. As for every disease, obesity also has a relationship with stone disease. And what exactly happens? Why stone forms into the renal system? Whatever we take, whatever getting excreted in the urine is to be in the normal levels. If there is any increased in urine calcium, increased in urine oxalate, there tend to be a lot of material collecting in the pelvic calyceal system. But when it gets collected more, it gets crystallized. Once it gets crystallized, and over that growth happens and it becomes a stone. So what are the types of stone we have? The common are up to 80% of the stones are calcium stones. Majority of them are calcium oxalates, and calcium hydroxyapatite comes next. And next there are stones which are non-calcium containing, which are uric acid. Infection related stones are called struvite stone, and stones which are due to drugs we take regularly for some other disease, and stones which form because of some abnormality in the urinary tract or due to some congenital metabolic disorders. So what exactly happens in stone disease? If you have more amount of calcium getting excreted in urine and more amount of oxalates excreted in the urine, which forms the crystals. To counter that, if you have more citrates, these things get dissolved and come out in urine, and you have more magnesium, it helps in preventing stone formation. And apart from that, you have disease like gout, cystinuria, where the stone formation can happen. So what is the main reason for more calcium coming is, one is dietary intake, the number two is amount of water, amount of fluids we take per day. At least this is decided essentially on not how much you take, how much you void per day, how much you pass water per day. It should be at least 2 liters in 24 hours period. This is essentially we tell to all our patients who are formed stone, come to us, see to that they at least void 6 times in 24 hour cycle. Each void usually approximately 300 to 400 ml, and 6 voids in 24 hour cycle, essentially they have reached the level where the possibility of stone formation comes down. So how to go through and identify this fellow has particular type of stone? I do some investigation, there are shadows in the X-rays, or ultrasound shows some stones, or CT scan shows some stones. Simple urine test can be a useful thing. If the urine pH is low, there is a high possibility patient has a uric acid and oxalate stone. If the pH is high, it is commonly infection related stone. The patients who are on various reason or many drugs like Septron, Triamterene, Indinavir, where they can present with colic, you will have to be very cautious. This can be because of the drug they take for long duration, which get crystallized and produce colic. There are issues where you give some medication for stone disease, that itself can be a problem for stone. For example, thiazide, which is a commonly used drug for hypercalciuria, they can in turn may be a problem in forming stone by creating acidosis. And excessive vitamin C and D, again, if you have give patient lot of vitamin C, if they have a low pH in urine, they in turn form stones. Apart from most important thing as a urologist, you should rule out any congenital anomalies, PUJ obstructions, horseshoe kidneys, calicial diverticulum. These are smaller problems where can be managed surgically. There won't be any problem to the kidney as well as the recurrent stone formation. What is PUJ obstruction? Urine getting collected into the kidney comes out through a tube. If the tube joining the kidney is blocked, a lot of urine gets stagnated in the kidney, which in turn forms stone. This is one. And the kidney, both kidneys can get joined in the lower level. This is called a horseshoe kidney, where a lot of stasis happens in the pelvic calyceal system, that in turn forms stones. And there are, I would generally tell my patients, there are 2 things in the kidney. One is the filtering portion, which takes the blood, filters it, which is the most important thing. Then the collecting portion. The collecting portion takes the urine, send it to the ureter. So if there is any problem in the filtration due to medullary sponge kidney, where there is some congenital problems where the calcification happen in the medulla, where the filtering portion of the kidney, then also the stone extrudes into the pelvic calyceal system and cause problem. This is the few pictures I have put in, the types of stones when you look at the electron microscope. So how do you identify this? The patient is suffering from stone problem. The common presentation of stone problem is pain in the plank. They will have a severe pain, intolerable, they will be restless, will not be comfortable in any position, they were moving around, they need a painkiller to get rid of the pain. And always you will see them vomiting, and they have some blood in urine. So this combination of 3 is the most important findings we see in patients with ureteric stone. There are many patients with renal stones. If they grow bigger also, they are silent, they don't cause any problem, they can present with infection. There are situations these stones grow bigger and bigger on both kidneys, they lose the function and they go to a nephrologist, they identify they have stones and come back to us. That situation, even though it has come down, still we see some patients. And very rarely patient can present with not passed water for 24 hours, 36 hours without any colic, where the smaller stones or the bigger stones blocking the PUJ, smaller stones come and block the both vesico-ureteric junction. PUJ, as I told you before, it's a junction between kidney and the ureter. VUJ is a vesico-ureteric junction where it is the junction between ureter and the bladder. And they suddenly say, I am not passed, they started swelling up, having some breathlessness. You see them presenting with abnormal renal function, doing an investigation which clench the diagnosis. These are the patients, the renal failure is completely curable when you have gadgets. And there are, why I tell that, because I had a bitter experience. I was new to this place when I came in 2003. I happened to watch a Jehovah Witness whose hemoglobin was 5 and renal failure, left, and we were not able to, because she presented with renal failure, with urosepsis, and we did our maximum to make her come out of the problem. We were not, because the lack of gadgets at the time. I hope things will change in QVH, and most of the time these patients with stone disease who are in 40s will present like they have some prostatic disease. They will have increased frequency, urgency, dysuria. You think, oh, I used to see. The earliest thing I would put it, because when you refer to some previous incident, it looks more relevant to talk. Which are the things I feel. The earliest patient I see with CA prostate is 38 years here, which I can never imagine in India. I have not seen CA prostate beyond 50, before 50 years there. So any patient presenting around 40s with LUTS, we always think it is related to prostate. But in our part of the world, lower urinary tract symptoms like urgency, dysuria. Dysuria means pain while passing water, and sense of incomplete emptying, straining to pass. These are, when the stone comes to the lower ureter, are the common symptoms. So essentially, when these symptoms come in, a patient come to you, we do ultrasound, which is a baseline investigation. It will give us the information whether patient has stone disease or not. It is not going to give us treatment plan. Unfortunately, ultrasound has its own problems. It is done by an expert, done by with best machine, done for a very nice thin patient, it works. And most of the patients who are obese, and you have a problem in identifying stones. So deciding on ultrasound only, I had very bitter experience here or even in Chennai. So I no longer believe in only ultrasound when the patient present with typical symptoms of ureteric stone or a renal stone. I confirm with a CT scan or a simple plain CT is more than adequate with reconstruction, because we are not looking at any tumor, we are not looking at anything we are going to miss. So ideally, CT scan, which is 6 slices, will do. With a reconstruction done by a good radiologist, you will be able to identify the stones. Definitely renal function, which I was telling you, there are most of the situation, bilateral obstructions need to be treated on the day, or within few hours the patient comes to you. So basic renal function analysis, blood functions is a must. And the urine culture, who emergency patients, we treat them and see to that we collect the urine before we start the treatment. And patients who are electively posted, all the time they have a urine culture ready, because this is a major problem in India where MRSA is a big pain. That is methylene resistant. Most of the drug they are resistant. I would not say it's MRSA. They are resistant to all the drug available. So we left with 1 or 2 drugs. We are worried when we are going to go out of antibiotic on those patients, and the investigation for assessing the calcium level, parathormone level, which we don't generally do on the same day patient come to us. These. So before we go to the treatment and plan, how urology and endoscopy evolved. As Hippocrates said, I will not cut for stone. The way the urology started, they started with rigid scope in 1806, and the first person was Bossini, and later they made a lot of changes, and Hopkins rod lens came in. The first thing came into the thing was for lower tract. They were doing a lot of cystoscopy. The first ureteroscope done was using a cystoscope. The patient had a vesicular reflex of grade 4. That means that whenever the bladder is pushing urine outside, no urine should go back to the kidneys. We have 2 kidneys, 2 ureters joining the bladder. The bladder, whenever it gets filled up, you get a signal from the bladder to the spinal cord, to the brain. It says the correct place to void. It says yes, you can pass water, you pass it. When you pass water, there should not be any backflow of water into the kidneys. That means your kidney is going to get affected. So one of the patient, the guy passed an endoscope into the bladder, and he saw another opening. He passed it inside. The patient had a large opening, patulous ureter. So rigid scope came in, where you can pass endoscope into the ureter, that is a tube which connects to the kidney and the bladder. There are various sizes of come in. Initially it was 12 French. 3 French is equal to 1 millimeter. 12 French means 4 millimeter. And now we have scopes for 1.5 millimeter, 2 millimeter scopes where we can go in. Various brands are available. They are very durable. They are semi-rigid. They are made of metal. They are not very costly though. So being urologists, we are used to angles. We love angles, We want to see the patient straight and lower down, still more like that. That helps us to identify all the nooks and corner of the bladder when they have disease in the bladder. And it helps to work in laparoscope better with less strain on the laparoscopic surgeon. So I mentioned a few angles we use for routine stone work. Most of the time our angles are 0 to 5 degrees. The next thing came up is the flexible scopes, where it's commonly used in gastroenterology. We just carried it from them. The long flexible tubes, we can pass it into the urinary tract. We can go into the kidney, see the stones, break them using the laser. Before laser, we were never looking at flexible scopes because all the energy source we have are rigid. We have a flexible scope, we pass a rigid instrument inside, our scope is gone and we cannot be able to perform anything. When laser comes in, which is a flexible thin wires which transmit the laser from the energy source, which helped us to work better in breaking stone. Then everybody, we start from analog television to the digital television, 4K television, like that. The medical field also moved in from analog to digital and to 3D. And in fact, after 3D, people moved to robot. Fortunately, we are surviving. The stone disease still with urologists who don't use robot, which is not really needed. Most of the laparoscopic work, especially when it is involving the prostate and removing the small portion of the kidney for tumors, were taken over by robotics. In fact, I was reading an article about robotics, which says, RIP to partial nephrectomy and radical prostatectomy, which is sad to see. So what are the advantages of going to the newer gadgets? One, you are going to give a better treatment. Number two, patient is going to go earlier to work, going to go home earlier than the time we used to keep them. And what are the disadvantages we have? More the gadgets, more the cost of the procedure is going to go up. More the cost, less people are going to afford. And still you are going to have a big population of people who cannot afford but want to have the treatment. So you will have to make a compromise. In fact, still you can work with non-digital scopes for most of the stone work, unlike laparoscopy, which I strongly feel you need to have a digital scope to go further. So this is apart from we are talking about how to move around taking care of the newer gadgets. There should be an important reason we should keep the scopes sterile for each patient. We should keep the scope for longer time so that we can use for more patients, and it should be done in a proper way so that it's saved from damage, it's saved from spreading infection, and it's saved from using it many times with less cost to the setup you are working with. Because unlike we are talking about sterilization in a open surgical method, everything is sterilized, autoclaved properly. We are 100% sure things are fine before we proceed. Unfortunately, in endoscopic procedure, many of the instruments cannot be autoclaved, especially the flexible instruments, they cannot be autoclaved. So you will have to be, and there are some company telescopes cannot be autoclaved, and autoclaves was improved, prevented many infections in any setup. So still we have issues in treating patients using endoscope. So we were looking at which is the best one for sterilization, and this is the, I don't know, we have it in QVH. This is the best state-of-art sterilization method, where your soakage time is 20 minutes and it kills all the bacteria, virus and fungus, and it is see, in our center I would say we do at least on a busy day up to 14 to 15 procedures. We start at 9 o'clock in the morning, end at 7 o'clock in the evening. Most of our surgical work start around 10:30. We are actually 4 colleagues working together. 2 of them perform most of the work in the morning, 2 of us perform in the afternoon work. So to have so many procedures done, you will have to have short sterilizing time, and not only short sterilizing time, it should be properly sterilized. So when we look at it, best sterilizing, this is the state-of-art sterilization method. This is the part related to sterilization, and urology is, as a urologist, radiation, having source to see a patient, that's fluoroscopy, or using some source to see the patient's stone. This is the third eye to me. Without C-arm, I cannot work in urology, especially if I do endourology. Endourology, essentially you see the stone through your eyes as well as through a machine, which helps in localizing the stone, helps in manipulating the stone, helps in removing the stone wherever it is. It is in the ureter or in the kidney or in the bladder sometime. So I am not going to go detail on the basics of radiology, but the common fear which I see everywhere when there is a C-arm on, which is the radiation source on, all the physician, all the SHOs, registrars, nurses disappear from there, say no, there is radiation. The newer things have changed it. The amount of radiation you get if you are away from 1 feet from the patient, you can see that it comes down drastically, and away from 2 feet, in fact you are 3 feet from the patient, you are almost not going to have any radiation, even though you don't have a protection. So if you have protection, you are going to be fine if it is 1 feet, you know, but that does not say you can misuse radiation. There are people, every time they want to see the location, they just go on pressing the fluoroscopy foot switch to see what is happening. That should be definitely avoided, so that, you know, you save the machine as well as the man. The side effects, as I was talking, you can, if you are very careful, you can prevent all those things. So when patient come to you, what you are going to do to them? When they present to you with pain, definitely you need to give them painkillers. You know, painkillers are the baseline in any urological pain. The only thing you should be very careful, you should not just give them Voltaren without knowing the renal function status, which I see quite commonly in any setup, India, anywhere in the world. They do not know the basic renal function of the patient. They give a painkiller which affects the kidney. Already the patient kidney will be under stress. So you should try painkillers which is not going to affect the kidney. There are many, you can try one of them, and if the pain is not relieved, wait for the function report before you start them on NSAIDs, which is going to affect them. I have had patients who renal failure took nearly 3 to 4 weeks following simple Voltaren injection. So we plan treatment based on the size of the stone, location of the stone. It's very simple. So if the stones are very small, between 5 to 6 millimeter in size in the kidneys, we just observe them and tell them most probably you will pass it out with pain. So have the painkiller all the time with you, safe painkiller though. And ureteric stones up to 6 to 8 millimeter. There are people, especially women, postpartum, that's like they are in 30s and 40s, they can, I have seen people passing out 10, 12 millimeter stones, just like that. So you need to do is help them, give them some medication to relieve the pain, give them the medication to expel the stone. So what is essentially, what drugs helps in pushing the stone out? They call medical expulsive therapy, MET, where you have alpha blockers which helps in dilating the lower end of the ureter, prostatic urethra. So thus that helps in pushing the stone whenever you take adequate intake of fluids. So you advise the patient to take plenty of fluids. If they have vomiting, give them some medicines to prevent vomiting, so that let them get hydrated well, and give them some medicine which push the stone. You can wait up to 4 weeks time, nothing is going to go wrong if the renal function is normal, and inform them if they get into any problem like increase in temperature, persistent vomiting, persistent pain, they can always come back to the doctor to see. So next, when we have stones bigger than that, we have a plan, whether it's Isovol or retrograde intrarenal surgery. If they are in kidney, less than 2 centimeter, and if they are less than 1 centimeter in the calyx. Now slowly, because as surgeons we always want to treat the patient complete. The Isovol, otherwise ESWL, it is called extracorporeal shock wave lithotripsy, which is nothing but you have electromagnetic source which delivers shock waves. You use some medium like ultrasound and X-ray to focus the stone and deliver shock waves on the stone. These shock waves are delivered in particular interval, particular time, particular intensity. The stone breaks and comes out as smaller bits in urine. The problem in Isovol is related to patients who are very obese, patients who are having bleeding related issue, bleeding diathesis, patients who have very hot stone, patients who have stones which will not usually break with ESWL. This thing will not work. And slowly the endourologists taken away ESWL in stone management in most of the world. We our numbers were 70% when I went in. Now our numbers are only 10%. So most of the thing I see, because nothing like seeing. You are depend on X-ray and ultrasound, which is not going to be accurate. I've been talking about it. So you can pass an endoscope into the kidney, see the stone. In fact, off late, if they are small, I break it into two or three, remove it. Nothing like removing the stone complete. You leave any bit, there are more bits going to grow over it. So always stone management is essentially complete removal. So the stones which are bigger than 2 centimeter, stones which has just filled whole system, otherwise they are called stag on calculi, and stones which are in the dependent portion of the kidney, which are bigger than 1.5 centimeter. These are the patients who definitely will have to have antegrade access, which is called PCNL. We make a small cut which is around a centimeter or below. Of late we are making cuts for within 3 to 4 millimeters. We access, I am going to show you a video how it is done later. So same applies to the ureter, which is a tube which I was talking from the kidney to the bladder. We divide them into upper, mid and lower portion. Upper portion of the ureter, we use one of the two methods which I have told you, eyes wall or flexible ureteroscope. Mid and lower ureter, we always pass a semi-rigid scope. I have mentioned about laparoscopy. I would say I have used laparoscopy for a few patients. In fact, one of the patient I used was a patient had a pelvic kidney where accessing the stone, the kidney was abnormally placed. Usually kidney placed in the back upper portion, lumbar region. When it comes stone placed in the lower abdominal level, there will be a problem related to drainage. Where you pass an endoscope, you will be able to see the stone. You break the stone, those stones will not come out because they are very dependent portions. Where there will be associated problems like blockage between the kidney to the tube, where the laparoscopy will be more useful. Which I have explained about lithotripsy, which is eyes wall is one method. We can, the source of energy we break, which I was talking about. Initially they were using electric energy. In fact, I used it when I came here, using electro-hydraulic energy, which can be still tried on bladder stones, but they are very dangerous. They can cause injury to the mucosa. There are situations the patient get into rupture of the bladder. Till that period it can go. It is only used for bladder stones off late, but most of the time people avoid it. Then came ultrasound. This is the safest, best energy used so far in kidney stones. The problem with the newer gadgets, they tend to combine with other source. The other source which I am going to talk is only using pneumatic, which is nothing but you see people using pneumatic jackhammer to break the stones, big stones. Same technology applied. You as a jackhammer effect use the stone to make it pulverize, and all this make them small. And initially people were thinking make them small is not adequate, you remove them. So we pass a forceps and remove it. Multiple time you pass a forceps inside the system and remove it, there is a tendency to form changes in the mucosa, the lining of the tube, and cause injury to the tube. So we were very hesitant. Then came the laser. What laser changed? How laser changed the scenario? I can make a stone like a powder, which is not possible in any of those methods, and it is safe. I cannot, unless I close my eyes and break the stone, I will not going to cause big damages to the mucosa, because the reach is only 1 millimeter. Even though I try many, the energy is reaching only 0.5 to 1 millimeter. So it's not going to reach beyond particular level to cause a big damage. So the problem with laser is also there. You are going for a more, as I was talking, you are looking for a better gadget, you are going to pay more money on it. If you pay more money, it's going to, maintenance is going to be more, and disposables are going to be more, and the cost of procedure is going to be more. If it is, there are many types of laser. When you use Volmium Nd:YAG, the biggest advantage is it is reusable. That's the way we look at it. Anything we are using, we cannot just throw things when you use one time. This can be reusable. We have fibers which last for 200 patients. You know, it will cost only 100 to, so I would say 1,000 Bajan dollars. You can still use for 200 patients when you have a laser energy. So how to use laser? I am not going to go further on this. You know, you will have to be careful when you use laser. You should have protective glass worn. You see to that it is not used without people around you knowing it. That's most basic needed. You know, which I was talking about before, retrograde intrarenal surgery, where is a tube, small thin tube goes into the kidney. Through that I pass a energy which will break them into smaller bits. The advantage is I can move the flexible scope all direction, which sometimes I feel I cannot do it when I do a PCNL, where I go use a rigid scope, try to remove a stone. So they had a combination now. You can do a supine PCNL and a flexible ureteroscope together. So you remove the bulk of stone, use a flexible scope, unreachable thing area, you pluck the stone, get it near to it, you remove it. So in that way you remove the stone completely without leaving any residue, which is the basic thing which I was telling again and again. So this is a patient who had stones. You can see on the left thing, the white things are the stones, you know, which has been treated. There are no stones both sides. The right side has been treated with Iswal, the left side flexible ureteroscope. And I am going to show you this is another patient who had a big stone on the right kidney, and you can see a shadow here. That's the lower ureteric stone, the small one. It's treated both sides. There are various settings to break a stone, which I was talking, you know. There are, you can make multiple small bursts and continue to do it. You can break. These are for hard stones. You can make them like you see in a cinema hall where, you know, people sell popcorn. It's burst like that. You can use energy to make the stone jump around, and you can dust the stone into smaller, finer bit. So what are the problem in using a thin scope into the kidney when the patient has infection? Ideally it should not be done. When you are a learner, you should have some learned person around so that you should not damage the scope as well as the patient's anatomy. And there are situations where you try to remove the stone using the basket gets stuck, you are not able to get rid of the basket. You know, you are, you know, those situations you will have to have some other method to go around, get rid of the problem. And as I was telling you, the common problem in any stone related treatment is incomplete treatment. So when you do incomplete treatment, you are going to see them again, probably, you know, short duration time, and bleeding, which is very rare compared to what we see in PCNLs, where we make a small puncture in the back and go into the kidney. And PCNL also evolved from, we started making 1 centimeter small hole in the back. This procedure is a innovative procedure, I would say, because it is done in patient lying down facing the floor, not looking up. So completely lying down facing the floor, otherwise called prone position. We use gadgets like ultrasound, X-ray to focus the area where we wanted to enter, which I will be showing in the video later. Initially the scope size were bigger, like what we see on the right side. Gradually it becomes small. We have scopes available now, 6 French through the small hole. So the biggest advantage, I am able to see the stone better. I don't have any problem in losing the stone because it's moving around. It is definitely less cost effective compared to the flexible scope. So, PCNL has 3 steps. 1, you will have to access the kidney. 2, you will have to dilate the tract where you are going to reach the stone. 3rd is the removal of the stone. This is a patient, as I was telling you, patient is lying down prone, face down, you know. I am, you can see me using a needle which from, there are 2 monitors. One is a fixed one on the back which shows only the X-ray. The other one, dynamic one, you can see my hand movement in it. You can see this needle going into the kidney. The black area or the contrast which is put into the system where through the urinary passage we pass a small tube into the kidney. This tube we fill the contrast material so that we can fill the system before we puncture when you use X-ray. If it is done by ultrasound, you can just pass a guided needle. You can see the clear fluid coming from the back. That's it. That means you are in the pelvic calyceal system. You pass a wire over the hollow tube into the ureter. You can see the small, we usually use a glide wire or a J wire, which is, you know, it's a thing, depends on the surgeon who does. And I am dilating. This technique was initially started by the Seldinger people, medical people will know that. Though are the people who gave us the idea to enter the kidney without much blood loss. So gradual dilatation of the tract. This is Alken's dilator, which is a backbone of PCNL procedure. So once I am comfortably inside, I will pass you can see the blue color tube, over that a black color hollow tube. I will dilate and push it inside, keep the black hollow tube, which is a, by the way, this is my wife. Sorry to put it, because she is the person who owns this laptop though. That's the reason it comes in all the time and I do it. This you see the black hollow tube, which is the Hamplats, otherwise called as. So the previous video I showed you, I was looking at the stones from below. Now you can see me looking the stones from above. I am very comfortable standing without much stress on me. You see one small stone is moving around. This is the another stone which is in the other calyx. I forgot to tell you there was one green tube which is the pelvic ureteric junction. Sorry, because I am not able to, yeah, I'm sorry to repeat it. Yeah, now you can see at 12 o'clock there will be a green catheter coming in. Yes, that's the ureteric catheter, which is I passed through the urinary passage, you know. That's the guide for us all the time when we do a PCNL. Without that, most often you will be in trouble. So we are not doing PCNLs on only the big people, because we have a big stone problem in pediatric age group. The earliest patient I have operated is 6 months old. And this patient is 2.5 years. You see this amount of stone the child has. It's completely occupied the right kidney. There are multiple secondary stones in the right kidney. And you can see the pelvic calyceal system, where it is a nicely dilated system for doing a PCNL. And this is a C-arm view where I look at before making a puncture. This, I made the puncture, you can see the clear fluid coming out. The top one where you see my nephroscope looking at the stone, over the nephroscope, thin tube around, which is the Hamplats. Most of the stones were removed. There are some stones which are around the Hamplats. Sometimes, you know, making a puncture is more easier, but when you are going on working, the bleeding is going to be more. So we always avoid another puncture. So for this patient, I was able to remove all the stones. One near to the tube from the below, I was able to remove. There are a few bits here lower down. I was looking at it because the angle I entered, I am not able to see the secondary stones. For that, what I did was, I passed another needle, fine needle. I not dilated or did nothing. I used some saline, irrigated the tube. You see the stones from there moved in, come into the lower left X-ray with the C-arm view. You can see multiple stones comes down into the proximal ureter. Most of the stones removed. This is called intracalyceal puncture irrigation, which is a method where you can prevent another puncture without much problem to the patient. This is the stone volume of the patient. Finally, you see the incision made on the patient, which is the one with stitches, the other one for the small needle passed inside. This is the post-operative status where all the stones are removed. Whenever you have innovations, you are going to face more complications, because you are going to be more and more minimally invasive. You are going to see less and less of what you are doing. So the common problem, as you know, the kidney is the most vascular organ. It has lot of blood supply. All the blood comes to the heart, comes to kidneys, where they filter it, and once filtered, kidney goes back to the heart. This is a continuous function, so it has lot of blood supply. So when I make a puncture, dilate, it tend to bleed, and bleeding can be sometimes very dangerous, and torrential bleeding can happen. I'm not going to go into the complications of the PCNL, where it's more useful for people who are more doing a lot of PCNLs, but when you are careful in making your puncture, when you are careful in identifying amount of blood loss, when you are careful in checking with the anesthetist all the time whether I can proceed further, because this is one of the biggest advantage of PCNL. Unlike open operation, where you had a cut, big cut, 20-25 centimeter, you left a stone, you cannot go back and cut again and go inside. But PCNL, I have a patient of mine who I have done 5 times in 5 years' time. That doesn't mean I have left some stones. All the time cleared. Unfortunately, this patient, I did all the possible investigation to identify something wrong with metabolic thing, but I am not able to find one. But he forms stones, and stones forms in the place where I need to do only PCNL, where other method will not work. So why I am telling this is a highly repeatable procedure when it is done safely. So that is most important in stone problem, because most of the patients over a period, there is a data which says when you form stones, there is a tendency for forming stones within 5 years is around 20 to 30%, which is very, very significant. So I am just going to skip the PCNL complications though, which can be, where I can show it to some of the the consultants and residents in surgery. You can see the top, can you see? This is a patient who underwent a PCNL. The stone is not removed though. You can see the stent, you can see the stone which is in the proximal ureter. Can you give me an idea of this patient had a retrorenal colon? So we punctured nicely. We thought we are in the system. When we are in the system, we passed the amplets inside. All we saw is fecal matter. So patient who are thin, previously operated, patient who had low BMI. These are the guy, male. These are the guy you will have to be very careful. Even though we had taken a CT scan, we missed it. You can see the colonic shadow down there. That is the area we usually puncture to reach the kidney. So now we are very careful. We do CT scan on all the patients to rule out we don't miss anything. The treatment option we did nothing to this patient, we just kept the colostomy. As we do the nephrostomy, we passed a tube in it. That's it. Because we are not reaching the peritoneum. It's a retroperitoneal. We kept it for quite some time though before we removed it. We did nothing to divert his thing. The other patient, it is a simple pelviureteric junction stone. There is a stone which is around 2 centimeter. Following stone removal, you see the amount of hematoma around the kidney. Simple. We just punctured and removed it. It took only 10 minutes for us. That fellow blood, we need to give him 4 to 5 units of blood, and we waited for 2 months for the hematoma to settle. So once as I was again and again telling you about stone disease, it's not the treatment is going to be the complete solution to the patient. They are going to come back to you when you don't give them advice, what to do. They are going to come back to you when you don't tell them this to be done, this not to be done. You will have to have a check this time. If you don't follow all those things, they are going to come back earlier to you. So as I was talking to you initially, the first time stone former, we usually advise them to see to that they pass water at least 2 liters a day, which is most important, and reduce sodium. In present time, you take any junk food, it has got high sodium in it. So you will have to educate the population. We will have to educate the population, telling them to reduce salt in food, which is the major culprit. These salts cannot go back through the bowel, it only will have to get excreted in urine. When they get excreted in urine, they get crystallized, they form stone. Another major issue, in our part of the world, most of the Indians are eating less meat, and many of them are vegetarian though, like me. And more red meat, more possibility of stone disease. So educate the population to reduce red meat intake. So this is the first time patients we advise. Patients who had previous episode come back to you, had operation for bowel disease and previous medication, chronic medication, family history, those are the patient. We always do some set of tests which will give us whether we are identifying any of the pathology so that we can treat them. They present with normal calcium level, but normal calcium in urine, we advise them only potassium citrate. But they have more calcium in urine, normal calcium level, we add thiazide. The only problem with thiazide, as I was telling to you, which can cause acidosis, which in turn can be a stimulus for a stone formation, we advise them to give interrupted way. So probably once a month, in 6 months time, repeat it. Patient with high calcium level, always you will have to assess whether the parathyroid is hyperfunctioning, treat that problem. And uric acid patients, you can treat them with potassium citrate. So potassium citrate helps in increasing the urinary excretion of citrate, which in turn prevent further crystallization or inhibit excess oxalate excretion in the urine. So patients who have formed stones because of infection, that's the reason I was initially telling you about doing a culture on those patients. You will have to treat them with antibiotics. Post procedure, whether it is any type of surgical procedure for stone disease, even for any patients who had a catheter put in, any general surgical procedure, neurological procedure, cardiothoracic procedure, they should have a urine culture taken, because we are seeing many of the patients who get into infection because of iatrogenic reason. So you will have to, who are the patients who need to do test, which I have told before, and also some patients with single kidneys, with fractures, need to be followed up carefully, and they need to have an evaluation done. What are the tests? Always you see to that the stone is analyzed. Not the routine biochemical analysis, which will never work, which is the most inaccurate way to assess the nature of the stone. You will have to do a X-ray crystallography or infrared spectroscopy. One of the two methods, which is the ideal method. You will be surprised. There are people who have the diamond merchant, gold merchant, they have one. But unfortunately, even in India, it's not easy to have a infrared spectroscopy, which is a basic essential thing to identify the type of stone. And you will have to always assess the 24 hours urinary excretion level of calcium, oxalate, citrate, magnesium, cysteine, which will give us a guide whether what reason the patient has formed stone, so that based on that we can treat the patient. And renal function status is always a must, which I was talking to about. Urine pH is always a must, and culture definitely helps in prevention as well as treating the patient. So there are some myths about stone disease. People come to you, doctor, do I need to reduce calcium intake? Can I cut down all the calcium in my food? Surprisingly, there are evidence available when the calcium level is low or calcium level is high, patient forms stone. That's very interesting. When you have less calcium in your food, the oxalate actually gets absorbed more into the system. Those oxalate come out of the urine and cause oxalate, urea and stone formation. So when you have more calcium in your food, most often it gets bound with the oxalate and gets excreted in the bowel, through the bowel. But there are situations they get into the blood, they get excreted. So excess calcium supplements should be avoided. But normal need, which is around 1.2 grams to be taken for every patient, should not be stopped, And high vitamin C, which is very useful in patients with alkaline urine, patients with infection stone, but they are not good for patients with acidic urine or stones which are uric acid. So you should be very careful in advising vitamin C for all the patients. And same applies to thiazide and high oxalate food. Yeah, definitely high oxalate is going to take you to high oxaluria, which is going to be a problem for stone formation. There are people who ask about leafy vegetables, salads, this and that is going to cause stone disease. Compared to the evidence available on animal protein, salt, less water intake, these leafy vegetables have very less role, because nobody eats leafy vegetable every meal. In fact, people eat meat every meal. So everything in moderation is the best choice in prevention of stone disease. Don't overindulge in any single food which can be a culprit. And hardness of water. Doctor, my area, the water is hard. Is it the reason for my stone formation? There is no clear evidence available on whether the soft water or hard water which leads to the, more than anything, the less amount of water you have consumed. So why I always put in how much urine patient has passed over the 24 hours is a matter, because there are situations, people in Barbados who are under the sun can drink 5 liters of fluids, but they can produce only less than 1 liter. Then they are not adequately hydrated. There are people who live in United Kingdom where they can 2.5 liters, 3 liters, 3.5 liters, they can still produce 2 liters of urine, which is more than adequate for stone prevention. So carbonated water, as for everything, we will have to say yes. Obesity, carbonated water comes into everything. This is a major problem in any society. So I have told about the recommendation though. So thank you for listening to me about the stone disease management. I am going to go through a few slides about recent advances in managing benign prostatic hyperplasia, which is enlargement of prostate related to age. It's not cancer prostate I am talking about, where the majority of the patient present with same symptoms. They have difficulty in passing urine, they take long time, they feel they have not emptied well, they see the stream is interrupted, and these are the symptoms of prostate. They have significant urge to void. They see, doc, I am not able to hold. If before reaching the washroom I am wetting my cloth. These are the patients who will have to investigate on If the PSA is normal and your rectal examination normal, the prostate is big, you need to do some form of treatment. The treatment essentially, I would say, past decade changed the management for benign disease of prostate. People were operating 90% 10 years back, now they do only 10% of the time. So this is a newer invention where we use laser to enucleate. You can see the diagram I may put in where you use laser. It's nothing but open prostatectomy without incision. Very simply speaking, you do retropubic prostatectomy without making an incision. All the steps are same. I enucleate, put it into the bladder, use a small instrument which makes them into smaller pieces, and we remove them. So I'm going to show you the video. From then we are finished for the day. You can see this is a laser which makes a cut, and the biggest advantage is there is no bleeding at all. On an average, if I operate on a patient around 60 to 70 gram, my loss of hemoglobin is 0.2 grams. For a retropubic prostatectomy, I know my days will be with so much stress. I will at least lose 2 to 3 grams of hemoglobin. If they are bleeding, at least a gram. So it's nicely enucleated and pushed into the bladder. You see, this is the technique we do, which the biggest advantage, where here I used the biggest gland I have removed was 280 grams by retropubic prostatectomy, where we have operated is 400 grams through holmium laser enucleation. So once the gland is pushed into the bladder, this is the instrument which make them into smaller chips, and it sucks through into the out of the system. The material, this is why I put it this slide. Most of the lasers initially they were useful in treating prostate disease, but there were no tissues for histopathology. So holmium laser is the biggest advantage where we have tissues for histopathology, where even though the incidence of malignancy in a transurethral procedure are less than 10%, but still it is useful. So I'm not going to discuss further on the complication. These are the recent inventions which made urologists more comfortable in working. They are more stress-free compared to the days where they were using longer incisions to remove stones, where they were stressed of operating on prostate, and life has become good for the patient as well as the doctor. Thank you very much for listening to me.
Thanks, Dr. Jeevagan, for that interesting talk, which made the 9 months of urology I did making big cuts in people and taking out things with my hand completely irrelevant. In Barbados, we have a problem with basically obtaining equipment due to poor finances. So if you were to come back here and you could only get one of those pieces of equipment, which one would you put your money in?
I will not come back. The reason, it is not, I am not interested in coming back to this place. This is a wonderful place in the world. I always feel my best part of my living, I spent my two and a half years I was here. The best time I had in my life is here. Even though I had terrible trouble in managing my patient, because it's such a wonderful people we have here, and fantastic climate, beautiful temperature, you can move around any time, and all the time you see blue sky, and people who respect each other, which is not commonly we see in India. There is a divide between people who are well educated and poorly educated, divide between rich person and the poor person, which I don't see it here. This is all good, but what I expect Barbados to do further is to get the latest treatment come into the people so that they benefit from it. The urology is basically gadget oriented. If I have only one gadget, for example, I am looking at only having a laser, I don't have ureteroscope, what can I do? I can only see the laser machine, look at, oh, I am having the best machine in the world, but I cannot do anything. And if I am having some, to be other way I put it, no, still we want to purchase some instrument which is going to be useful for all purpose, pneumatic lithoclast will do. For all purpose of stone disease, whether you are going to do upper tract, lower tract, anywhere you can still go with it. Pneumatic, but you cannot do a flexible uteroscope, which is not a problem when you are trained in PCNL and semi-rigid scope, enough. Pneumatic, which is cheap. You won't believe, in India it is only $500 Bajan dollar you can get one. Reusable.
Are there any medications that you can give to reduce stone formation? Make the answer short, please.
So the evolution from magnesium, we are looking at sodium citrate. Initially, we are trying to increase the urinary excretion of citrate. We were started with sodium, then we found sodium is wrong. That itself is a stone former. So potassium citrate is ideally simple drug, which I am surprised to see it is not available in Barbados, which is nothing. It's like a fruit juice. It can be available anywhere, and which only a urologist can tell people this should be done, this should be available in the formulary, so that this reduces stone formation by 70% on patients who have been treated previously. So it is a significant, and it is not going to cost much. Yes. See, ideally we advise previous stone treatment up to 2 years. If they are not getting any stone recurrence, we just check them every year, then onwards. First 2 years, at least every 6 months, they should do an ultrasound or some form of treatment to identify they have not formed any new stones. It doesn't really say only you get potassium magnesium citrate here, you are going to prevent stone formation by taking enough meat, less water. That's going to not work. So dietary restrictions, water intake and medicine definitely going to reduce the incident.
You'd be amazed at the things that aren't available here. Anyhow, any other questions from the audience?
Damon Cole, pharmacologist. I came in late. I saw on one of your slides myths about, I guess, stones, and you had thiazides there. Could you just repeat exactly the point you were trying to raise as it pertains to the use of thiazide?
Yeah, thiazide reduces urinary excretion of calcium, which is useful for prevention of stone disease. Over the long period of time, when you have thiazides on, the patient gets into metabolic acidosis, which is a culprit for uric acid stone. So long duration of thiazide is definitely not advisable. So you will have to give a gap when you are trying to treat them, especially when they are, Thank you.
Thank you very much for a very excellent lecture, at least the part I saw. What I was wondering, some of those gadgets, could they be extrapolated when it's gallstone, or is it just the kidney stone?
Initially, Eisbal's ESWL was used for treating gallstones. It became a big failure. And nothing equal to laparoscopic cholecystectomy, which I feel the best procedure invented, which made most of the people have courage to go into laparoscopy. So that's the best procedure of choice.
I think we can answer that. See, the gallstones, the problem is if you pulverize the stones and they go down and block the outlet, then they develop jaundice. Whereas in kidney stones, because you can flush the kidneys, it's like a toilet, so you can flush the small stones and it'll pass out, and the passage is wider, so that is why it failed. Plus, if you have these gadgets, the surgeons will not have any work.
And also his gadgets came about to replace open surgery. We now have laparoscopic cholecystectomy. I mean, come and get your surgery, you're home the same day or the next day. There's no more this big cut that we used to make 40 years ago.
The disease which are recurrent, you cannot be cutting again and again. And you even though, there are situations where patients get into you every 6 months, even though you do most of the tests. So this surgeries made them comfortable and go back to work faster.
Thank you. If there are no further questions, I hand over to Dr. Bernstein.
Thank you. Good night, everyone. I'm Dr. Bernstein from QEH and faculty of Medical Sciences. I'm a consultant in surgery. Nice to see you all here tonight. I'd like to start off by thanking the Dean of the Faculty of Medical Sciences, Dr. Ramesh, and of course our guest speaker, Dr. Jiva, who used to be my registrar here in Barbados 10 years ago. A very informative and exciting talk for me. I had several kidney stones, so for me, I was very interested. I'm looking for some sodium citrate after this lecture to try and help me out. I would like to thank Christiane Walcott for a very professional organization of this lecture, the IT department, and of course you, the general public. Thank you so much for coming. Have a good night. Get home safely. God bless.